case study of a patient with acute otitis media presented by Chakiath Varghese at the Brandman University. A 9-year-old Asian female came to the clinic with a chief complaint of sharp pain in her right ear since 3 days. Patient stated that the pain is 8 out of 10. She cannot turn her neck to the right side due to the pain. Patient's mother said that the patient had low-grade fever for the past 2 days and she missed a day of school. Patient has not been active or she's not been eating very much. Pain comes and goes and patient cries when she is unable to tolerate the pain. Mother has given her Tylenol twice a day, but the pain medication is not working any longer and mother wants medication to make her daughter feel better and relaxed. As per her mom, the patient had frequent ear infections between the age of 1 and 3 years old since the patient went to a daycare. Patient was treated with multiple antibiotics and the doctor advised that she needs to have an ear tube placed to prevent infection. The mother stated that the family refused to have her go through a procedure at that time. She recovered from getting frequent ear infections after 4 years of age. She now gets on and off ear infection like once or twice a year. Surgical history, none. OBGYN, none. And psychiatric is none. Patient's father has type 2 diabetes mellitus. Mother has no significant medical history, but she underwent a C-section. She has no siblings and she lives with her parents. Patient takes Tylenol for pain and she does not have any drug allergies. She doesn't take any alcohol, any illicit drugs, no tobacco. She goes to school and her exercise is mainly swimming. She's up to date with all her immunizations. Vital signs. Her blood pressure is 100/75 mm of Hg. Her heart rate is 89 per minute. Temperature is 99.5 degree Fahrenheit. Oxygen saturation is 99%. Her weight is 45 pounds. Patient looks well nourished and well groomed and she makes fairly good eye contact, but she looks anxious. Patient's skin has no lesions, bumps, acne or pimples. There is no discoloration of the skin. She has no vision changes, no pain, redness, excessive tearing and double vision. Patient has no blurred vision as well. Patient has hearing changes, tinnitus, and she has right ear ache. She has discharge from the ear as well. Patient has no maxillary sinus tenderness, no itching, no heavy fever or nosebleeds. She has no bleeding gums, no crack on the tip of the tongue or no dry mouth. Patient has no sore throat. She has no lumps on the neck, no swollen glands or goiter or no neck stiffness. But she is unable to turn her neck to her right side due to the severe ear pain. Physical examination. Head, atraumatic normocephalic. Patient has no lesions. Eyes, sclera white in color, pupils equal and reacting to light. EOMI, patient does not use glasses. Ear, middle ear looks red and swollen. There is minimal discharge. Nose and throat. There is no discharge, redness or swelling. Tonsils are not enlarged. Face, symmetrical. Neck. No thyroid enlargement or no lymph node enlargement. Respiratory. CTA bilaterally, no wheezing or crackles. Cardiovascular. S1, S2 heard, regular rate and rhythm, no murmurs, gallops or lifts. Based on the evaluation and data collection, her differential diagnosis is acute otitis media. Recommended diagnostic testing. Pneumatic otoscopy remains a standard examination technique which will show the following: color. An opaque yellow or blue or red tympanic membrane is consistent with AOM. Position. In AOM, the tympanic membrane is usually bulging. Mobility. Impaired mobility is most consistent finding in patients with AOM. Perforation. Single perforations are most common. Other tests which are rarely performed are the following: culture of the fluid to identify the causative pathogens. The next one is tympanometry, and the last one, CT or MRI could be suggested as well. Treatment plan. Amoxicillin remains first-line therapy for children who have not received amoxicillin within the past 30 days. Amoxicillin clovelinate is recommended if amoxicillin has been taken within the past 30 days, if concurrent purulent conjunctivitis is present, or if the child has a history of recurrent AOM unresponsive to amoxicillin. For children with a non-type 1 hypersensitivity to penicillin, cefdinir, cefuroxime, cefdoxime, or ceftriaxone may be appropriate choices. Prophylactic antibiotics are not recommended to reduce the frequency of recurrent AOM. This is the American Academy of Pediatrics recommendations on the treatment of AOM. As I mentioned earlier, amoxicillin is the first line of antibiotics. Then comes the amoxicillin clovelinate, and there is alternative treatment for people with penicillin allergy. The key recommendation of diagnosis for children as per the American Academy of Pediatrics. The diagnosis of acute otitis media should be made in children who present with moderate to severe bulging of the tympanic membrane or new onset of otorrhea not due to acute otitis externa or mild bulging of the TM and recent, which is less than 48 hours onset of ear pain or intense erythema of the tympanic membrane. Key recommendations of management for children as per the American Academy of Pediatrics. AOM management should include pain evaluation and treatment. Antibiotics should be prescribed for bilateral or unilateral AOM in children aged at least 6 months with severe signs and symptoms. Amoxicillin is the antibiotic of choice unless the child received it within the previous 30 days or has concurrent purulent conjunctivitis or is allergic to penicillin. In these cases, clinicians should prescribe an antibiotic with additional beta-lactamase coverage. Clinicians should re-evaluate a child whose symptoms have worsened or not responded to the initial antibiotic treatment within 48 to 72 hours and change treatment if indicated. In children with recurrent AOM, tympanostomy tubes but not prophylactic antibiotics may be indicated to reduce the frequency of AOM episodes. Clinicians should recommend pneumococcal conjugate vaccine and annual influenza vaccine to all children according to updated schedules. Clinicians should encourage exclusive breastfeeding for 6 months or longer. The follow-up and patient and family education are almost similar to the key recommendations of management of children with AOM as per the American Academy of Pediatrics. The follow-up is clinicians should re-evaluate a child whose symptoms have worsened or not responded to the initial antibiotic treatment within 48 to 72 hours and change treatment if indicated. Family education. Following simple hygienic practices such as hand hygiene with regular soap or alcohol-based hand sanitizer can have a positive impact on the health of families in non-medical settings. Exclusive breastfeeding until at least 3 months of age reduces the incidence of AOM, and this effect persists 4 to 12 months after breastfeeding ceases. Pacifier use in children younger than 3 years of age increases the risk for recurrent otitis media by up to 25%. Limiting daycare exposure for very young children decreases the risk of upper respiratory tract infection and therefore AOM. Maternal smoking during the first year of life is a significant risk factor for recurrent otitis media, especially in low birth weight infants. Use of influenza vaccine is highly encouraged for healthy children older than 6 months of age and for their parents and caregivers. The pneumococcal conjugate vaccine is also recommended for children to prevent the AOM. Thank you for listening to this case study presentation.